Welcome to the 10th module of our educational program. So a review from last session on my end, we discussed activity-based coping strategies, natural remedies, and stigma. We learned about aerobic and non-aerobic activities such as walking, running, weightlifting. We also learned about gardening, yoga, and mindfulness. Gardening can increase physical activity and improve mental well-being. Yoga can increase cognitive skills and decrease anxiety. Mindfulness is effective in reducing depression and anxiety through being present. We learned about natural remedies that may alleviate symptoms such as lavender tea or oil, turmeric, omega-3 fatty acids, and vitamin D. We also learned about perceived stigma, or how you think about others' thoughts and beliefs, experienced stigma, experiencing that stigma directly, internalized stigma or self-shame, and stigma surrounding seeking mental health treatment or the treatment itself.
Last session, I discussed sensory processing disorder and how it relates to feeding. So sensory processing disorder, abbreviated SPD, is a condition that affects how your brain processes sensory information or stimuli. I discussed its symptoms, or those who are oversensitive to stimuli versus undersensitive to it. I also discussed sensory eaters and how eating can cause physical or mental discomfort for your child, but there are ways to help your child have a positive relationship with food. I also discussed messy play is one strategy to use with sensory eaters. The idea of messy play is to get used to how food items and drinks look, smell, feel, using hands and faces without any focus on eating and drinking. Lastly, I went over OT activities for the 5 senses. There are so many activities, and they included activities for taste, touch, smell, sight, and sound. So this session, I'm going to discuss oral motor skills and how they relate to feeding. By the end of this presentation, you will understand the relationship between oral motor skills and feeding. You'll be able to summarize the development of oral motor skills. You'll be able to list the different types of chewing. You'll be able to explain the impact of delayed oral motor skills. You'll recognize oral motor concerns. You'll determine how to improve chewing and other oral motor skills. And you'll choose oral motor exercises to try with your child. So a brief overview of oral motor skills and feeding. Oral motor skills include awareness, strength, coordination, movement, and endurance of the mouth, jaw, tongue, cheeks, and lips. We need these skills to effectively chew and swallow food. If a child has an oral motor delay or problem, they may not be able to chew or manage bolus well. Bolus is chewed food in the mouth before it is swallowed. Oral motor skills are needed to eat a thin puree off a spoon and to eat a carrot stick, which I know are very different. Pureed foods require minimal bolus management of a thin food that quickly runs down the esophagus with minimal effort. The carrot stick, on the other hand, requires the child to have awareness of their mouth, tongue, and bite pressure before even creating bolus with the bite of carrot. The child also has to manage the bolus and breakdown of carrot efficiently while chewing and then swallowing. Occupational therapist's job is to help these children become functional eaters through remediation of delayed oral motor skills. So the development of oral motor skills begins in the womb and is fully developed and established by 3 years of age. Like many other skills we learn, oral motor development is supported by primitive reflexes. These are involuntary motor responses present at birth. It also involves postural control, so the baby's ability to hold their head up without support, and other biological milestones developing simultaneously. When the synchrony is broken, problems arise. So again, oral motor skills start in the womb with the development of primitive reflexes that support feeding at full term. It is important to note that these reflexes develop in the third trimester between the 28th week and the 37th week gestation. When working with a preterm baby, these reflexes have not developed and successful feeding will require higher levels of support. These reflexes include the gag reflex, rooting reflex, which is the baby opens their mouth when the corner of the mouth is stroked or touched, the transverse tongue reflex, which is touch or stimulation of the tongue with taste on either side, and this will move the tongue toward that side. Also the non-nutritive and nutritive sucking reflex, the coordinated suck, swallow, and breathe movements, swallow reflex, the phasic bite reflex, which the baby opens and closes their jaw to bite up and down when you apply pressure to the gums, the palmomental reflex, which is the muscle of the chin contracts when the base of the thumb is stimulated, and sucking patterns are non-volitional, so the baby has no control of sucking patterns. A full-term infant is ready to breast or bottle feed with the above supports in place. As reflexes begin to integrate or fade away, feeding becomes more and more voluntary and less of a non-voluntary response to stimuli from the breast or bottle. This occurs in a full-term infant around 6 weeks of age. This is important to note as unsuccessful feeding in the first 6 weeks of life can set the tone for developing eating patterns throughout life. By 4 months of age, most infants have gained fair head control and are able to remain in an upright position with support, and parents are beginning to introduce pureed foods. As they have grown, the anatomical structure of their jaws and tongues have dropped forward to support munching patterns. They also may open their mouth when a spoon is presented and are able to manage thin purees with minimal difficulties. Babies develop oral motor patterns, including munching patterns, lateral jaw movement, which is moving the jaw side to side, diagonal jaw movement, which is downward movement of the jaw to either side with easy contact and release of food, and this aids in placement of food between the molars for chewing, and lateral tongue movement, which is moving the tongue from the center of the mouth to the side. The development of these patterns allow infants to be successful with thin and thick purees, meltable foods, and soft foods such as banana and avocado. Between 7 and 9 months of age, infants are now moving into unsupported sitting, quadruped, and crawling. This development supports jaw stability, breath support, and fine motor development for self-feeding skills. Infants at this age now begin to be able to successfully manage lumpy purees, bite and munch meltables, and softer foods with assistance, and the development of rotary chewing also begins. So oral motor patterns are seen at this stage, and they include lip closure, so closing the mouth around food, scraping food off the spoon with their upper lip, emerging tongue lateralization, which is manipulating food to be chewed and formed into bolus, and the movement of food from side to side. These skills are clearly noted during the 7 to 9 month age range, and if these skills are missing, eating a larger variety of textures will become difficult. By 12 months of age, the child has developed the oral motor basics to support feeding. As time goes on, the child will practice these skills, resulting in less messy eating and the ability to handle more challenging foods. At this age, a child is able to manage foods with juice and chew and swallow firmer foods such as cheese, soft fruits, vegetables, pasta, and some meats. Between 16 and 36 months of age, the child continues to develop their jaw strength, management of bolus, chewing with a closed mouth, sweeping of small pieces of food into bolus, and chewing harder textures, foods such as raw vegetables and meat. A full circular rotary chew should also be developed at this time to support eating all varieties of foods. So listed on this slide are types of chewing that babies have by 36 months. Rotary chewing is broken into stages, the first stage being diagonal rotary chewing, and the second being circular rotary chewing. So diagonal rotary chew is when the jaw moves across the midline in a diagonal pattern and comes back. And this type of chewing often looks like an X from a frontal view. As the child develops, a circular rotary pattern emerges. In this pattern, the child's jaw lines up, slides across, jaw lines up, slides across again, and this looks like a circle from a frontal view. And then rotary patterns begin emerging around 10 months of age, and again are fully emerged by 36 months. The child at this time is also developing the dissociation of their head from their body. This supports increased independence with biting pieces of food, the lateralization of bolus across midline, so again that side-to-side chew, and decreased spillage from the sides of their mouth. So what's the impact of delayed oral motor skills? So a child who has a delay in oral motor skills may have difficulty moving his or her lips, tongue, or jaw to produce a variety of sounds in speech. Weakness of the muscles of the lips, tongue, or jaw can also make it difficult to chew, swallow, and manipulate food within the mouth. This can result in episodes of choking or gagging that affect a child's willingness to eat. Oral motor skills further play a large role in a child being a successful eater and having a positive experience with food. When a skill is missing, feeding becomes difficult and stressful for everyone involved. By assessing where the delay in skill is, new skills can be developed successfully, leading to an improvement in both eating and speech. So, what are some oral motor concerns? So, issues with the following movements can lead to problems with feeding. And if you see any of these problems, you want to reach out to a pediatrician or your occupational therapist. And occupational therapy also helps notice these issues, and they address them in therapy as well. So jaw thrust is one, and this is when the jaw and mouth open suddenly with force. Your child could have exaggerated jaw movements, so this is a sign of jaw instability, and this may be due to decreased muscle tone or impaired oral control. Jaw instability is when the jaw slips and shifts due to insufficient tone and control as well. You also may see jaw clenching. This occurs when the jaw moves into a tight position and the child cannot utilize rhythm in eating and drinking. Tooth grinding may also occur, which may be associated with muscle weakness or abnormal muscle tone. Stability bite can also occur, and this is when they're presented with a spoon, fork, cup, or straw, and the child exhibits a stability bite, which is when they tightly bite down in order to gain stability during biting. You may also see a tonic bite, and this is when jaw closure occurs with forceful, sustained upward movement of the jaw, and it occurs following stimulation of the teeth or gums. You may also see jaw retraction, so this is forceful, sustained movement of the lower jaw, carrying it up and toward the back so that the alignment of the molars is displaced. Tongue retraction is when you will see abnormal movement where the tongue appears thickened and bunched, and the movement is retraction, so it's strong pulling back of the tongue into the back of the mouth, and this is also associated with abnormal increased muscle tone. You could also see tongue protrusion, so the tongue shows a forward movement beyond the border of the lips, and this movement is non-forceful. And then tongue thrust is another one you could see, and this is when the tongue is thickened and bunched, and the forceful movement occurs outward but on the border of the lips. How to improve chewing and other oral motor skills. So it's not uncommon for children with developmental delays to have deficits in some of the oral motor skills needed for chewing, or these deficits to be correctable. So one research study was effective in improving chewing and other oral motor skills. The treatment consisted of steps targeting tongue lateralization, again that side-to-side tongue movement in the mouth, lip control, and chewing practice. So again, tongue lateralization is the ability to move the tongue from side to side inside the mouth. This skill is necessary for chewing because the tongue is used to move food onto the chewing surfaces of the teeth. Tongue lateralization can be taught by having the child lick food from the corners of their mouth. Lip control is the ability to close the mouth when eating and drinking so the food does not spill out. Good lip control is needed for a child to move food around in their mouth. Lip control can be taught through having your child drink from a straw or an open cup. Chewing practice involves giving the child the opportunity to bite and produce the up and down movements of chewing. Small pieces of food are placed on the child's teeth and the child is prompted to chew. Dry, crisp foods that dissolve easily are used because they provide feedback to the child when they are chewed. So occupational therapy may use a treatment method like this in their sessions, and it may look like this. So step 1, you use tongue lateralization. You place a small amount of peanut butter, pudding, or cake icing in the corner of the child's mouth and instruct them to lick that food. You praise or reward your child for licking the food, and you want to do this for both sides of your child's mouth. You may have to start by rewarding your child for just sticking out his or her tongue, because some children cannot move their tongues to the corners of their mouth. This skill may need to be shaped. Have your child stick his or her tongue out and gently push it toward the side of his or her mouth with a Teflon-coated baby spoon. After practice, your child will be able to move his or her tongue to the corner of his or her mouth without assistance. Step 2 is lip control. You want to present a drink to your child with either a small open cup or cup with a straw. Praise your child for taking small drinks. As the drinking improves, gradually increase the size of the drink. Step 3 is chewing practice. So place a tiny bite of food to the child's teeth. Hold the food to the teeth until the child bites, then immediately praise the child. If the child does not bite, gently push upward on his or her chin and release. Continue to assist the child to chew until one bite has been taken. As the bites are taken without resistance, move the food onto the child's molars. So as the child is able to bite food, have him or her chew 2 to 3 times before offering praise. As the child continues to improve, increase the number of times the child must chew prior to offering praise. Take care during chewing practice to avoid having your fingers bitten. Modifications can be made to each of these steps to make them easier to learn or to increase the child's cooperation and compliance. So modeling or demonstrating chewing can be used to show the child what is expected. Praise can be used for compliance, or if necessary, other rewards can be used. As your child learns to chew, baiting can be used to gradually reduce the amount of physical assistance needed to close the lips or chew. These strategies can be used during snacks or before meals. When you first implement them, limit their use to only 1 or 5 trials of each step. In this way, the child can gradually develop a tolerance for them. What is the importance of oral motor exercises? Oral motor exercises work on improving mobility and functioning in the mouth, tongue, lips, and jaw. When we talk about oral motor exercises, it's important to know why we are considering specific exercises. So when it comes to these exercises, we are striving to improve the functioning of the mouth, jaw, lips, cheeks, and tongue so that the child can demonstrate coordination needed for sound production and articulation. Other issues can arise in manipulation, such as chewing, movement of foods and liquids, tolerance of various textures, and swallowing foods and liquids. Kids who struggle with feeding may be impacted by oral awareness or oral discrimination. These skills enable us to both be aware of the motions of the muscles and joints of the mouth and to enable positioning for oral sound creation as well as movements to control and mobilize the chewing and manipulation of foods and drinks of various textures. Here is a video of some oral motor activities you can do at home with your child. Listed on the next few slides are examples of oral motor exercises and activities. Consult with an occupational therapist before performing these exercises. Exercises should be selected based on the specific needs of your child. An OT will tell you how many exercises to do and how often, as well as instruct how to make these exercises functional. So I'm not going to read over each slide, so you can pause the video and read the exercises and activities listed on your own. So a knowledge check question for you. Select one. Which of the following is an oral motor concern that can lead to problems related to feeding? Is it A, tooth grinding, B, jaw clenching, C, tongue protrusion, or D, all of the above? The answer is D, all of the above. On this slide, I have some resources for more oral motor activities and exercises to try with your child. I will provide the links below.
For this module, I will be discussing increasing parenting self-efficacy or confidence. So why is it important that we discuss parenting confidence or self-efficacy? So self-efficacy is defined as an individual's belief that they have within themselves to complete a task or execute a behavior. So for parenting specifically, we're going to refer to self-efficacy as a parent's belief in themselves to parent effectively. So mothers are most affected by this because their role or transition into motherhood is so prominent, and many things change throughout this period of time, physically and mentally. We want to learn about parenting confidence because self-efficacy can impact a mother's mental health. If a parent feels that they are incapable of parenting effectively, this can lead to depressive symptoms and poor mental health. Self-efficacy can also impact your child's psychological development. As we have been learning, a parent's mental health status can have many effects on children as they grow. Most importantly, mothers need education on these topics in order to develop sensitivity, attachment, and responsiveness to their child. Having parenting confidence or self-efficacy is crucial for both the baby and the parent. So what can low self-efficacy or confidence lead to? It can lead to an increase in depression symptoms, more controlling parenting behaviors, behavior difficulties in children, higher stress levels, and use of poor coping strategies. And on the other hand, what can high self-efficacy lead to? So high self-efficacy can lead to being sensitive and responsive to your child's cues, active parent-child interactions, utilizing healthy coping skills, and creating a happy and nurturing environment for the child to develop in. So how can we improve self-efficacy? Research shows that self-efficacy can be changed through education. Some topics that are often taught about in order to improve self-efficacy includes appropriate parenting behaviors and styles, effective discipline, and positive interactions. Also, education on child development. First, I'm going to teach you about the 4 main styles of parenting. This is important because, as we discussed before, the attachment children form to the parents is important for both the child's development as well as the mental health status of the caregiver. We want a secure attachment between parents and children so that the children know that their parent is going to be there to meet their physical and emotional needs. The 4 main styles of parenting are authoritative, authoritarian, permissive, and neglecting. I will discuss what these style types mean individually, and I will also explain the attachment style that this parenting style creates between the parent and the child. Negative parenting styles can also increase susceptibility to depressive symptoms. The first parenting style we have is authoritative parenting. This parent has a high level of demandingness and acceptance. The attachment style that is formed with this style of parenting is secure. The parents are sensitive to the child's needs and provide a balance of discipline and acceptance. They respond to their child with warmth and kindness. Next, we have authoritarian parenting. This parent has a high level of demandingness and a low level of acceptance. The attachment style that is formed with this parenting style is avoidant. These parents are often very strict and controlling of their child. A child can have more depressive episodes, low self-esteem, and anger with this style of parenting. Next, we have permissive parenting. This parent has a high level of acceptance and a low level of demandingness. The attachment style that is formed with this parenting style is ambivalent. The parent is usually carefree and inconsistent. Due to this, the child is likely to have less self-control and less self-confidence. Next, we have neglectful parenting. This parent has a low level of acceptance and a low level of demandingness. The attachment style that is formed with this parenting style is avoidant. The parent is usually cold and unresponsive. The child is likely to have impulsive behavior and struggle with drug or alcohol abuse in the future. These children are also at higher risk for suicide or suicidal ideation. Next, we have effective discipline. So within effective discipline, there's the cognitive approach and the behavior modification approach. The cognitive approach is providing the child with a rationale as to why they are receiving discipline. The behavior modification approach is providing positive reinforcement for good behavior and providing negative sanctions for misbehavior. So what kind of parenting styles and discipline do these parenting styles use? So authoritative parents tend to use praise and rewards, removal and timeout, and also reasoning. So authoritative parenting style is the ultimate type of parenting style, and they use a little bit of everything. Authoritarian parents tend to be overly negative with their sanctions, very punitive, and they provide usually no reasoning to the child as to why they're receiving discipline. Next, we have non-effective discipline. So this is a controversial form of discipline, and a lot of individuals have differing opinions on this. But like always, I'm providing evidence-based research on this topic, and here's what the literature states. Some authoritative parents have reported using normative spanking, and I like to think of this as a gentle, non-injurious spanking to correct behaviors with success. My take on this form of punishment is that if it can potentially have an effect on the attachment and the relationship between you and your child, finding a better form of discipline is a better route to go. There are a lot of other effective ways to correct the behavior. So physical punishment is shown to be no more effective than less punitive discipline, and it can disrupt that child and parent relationship and attachments. So what are strategies we can use for effective discipline? So first would be set limits. A child should know what is considered bad behavior or actions. For example, climbing on top of the counter or slamming doors is known throughout the household as unacceptable behavior. Next, be consistent. If a child demonstrates an action that is considered to be a no one day, it should also be no the following day. If a parent gives in to these rules because they are too tired, for example, to enforce the rule that day, the expectations are then blurred to the child and they will expect for that rule to be bent again in the future. Next is set clear expectations or consequences. So saying you have until the count of 3 or you're going to time out, this gives the child a choice to correct the behavior. You also want to set clear expectations for yourself, being aware that children don't always have perfect behavior, so keeping in mind their stage in life and maybe the setting you're in that day can be a helpful way to stay calm and collected. Next would be reinforcing good behavior. So saying things such as, I love it when you're kind to others, or it was so nice of you to share with your brother, or even providing rewards such as, you had such good behavior today, maybe we can go out for ice cream. Next would be mindful of your own mental state. So knowing that you might react negatively more quickly on those days where your mental health is not great could be a good way for you to be able to regulate those emotions that you have when your child is demonstrating bad behavior. Next, we have positive interactions. So having consistent positive interactions with your child can lead to higher confidence in the child and having a secure attachment. Parental warmth and support can lead to lower depressive symptoms in the parent or the child, less physical health problems, and less risky behavior. So what are examples of some positive interactions? So these can be giving compliments, praising your child, doing an enjoyed activity with the child, setting specific time together, teaching positive behaviors, and active listening. So the rule here is to just try to aim for having more positive interactions throughout the day than negative. So the next section we have on education to increase parenting confidence is child development. So if your child is in early intervention, I'm sure you're somewhat aware of these milestones, but it's important to remember that every child is different and not every child will hit all of these milestones. I'm just providing this information for a general guide and sequence of milestones. There are resources on the CDC website that contain specific milestones, starting from 0 months to 5 years old. Within the first 3 years, these are usually chunked together in 3-month markers. For the sake of time, I will just cover the milestones that are generally met around the first, second, and third year of your child's life. These will be split up in between motor, sensory, communication, and cognitive milestones. So some general milestones for 1 year old would be putting items into a container, understanding no, waving bye, picking items up with thumb and pointer finger, and walking holding onto furniture. Some more general milestones for 2 years old, we have noticing others' emotions, pointing to items in a book when asked, saying 2 words together, playing with 2 toys at a time or doing 2 things at once, kicking a ball, running, and they start to eat with a spoon. So next is general milestones for 3 years old, and that is playing with other children, asking who, what, where, and why questions, drawing a circle, stringing items together, such as maybe macaroni noodles onto a string, and using a fork to eat. I gathered some resources surrounding today's module. So the first resource I have is a parenting confidence workshop. These do cost money, but it seems as if insurance may cover them. There are a different series of workshops, but the URL I have listed here will take you to the one that is for ages 2 to 7. In these workshops, you can learn about effective communication, the link between behavior and brain development, responding to children's more challenging behaviors in ways that parents are comfortable with and that works for them. And to attend, you will need to register with the link. I also found a free Facebook group if you're on Facebook. It is called Parents with Confidence. So if you search that, it'll come right up. It looks like a good place to connect with other parents, and the creator of the group often shares great resources. So a knowledge check to finish my module for today is this type of parenting style is known to create a secure attachment between the parents and their children. Is it authoritative, authoritarian, permissive, or neglecting? The answer is authoritative. So authoritative parenting uses an equal amount of demandingness and acceptance. They often are sensitive to the child's needs and respond to them with warmth and kindness.